Yes, please start.
Okay. Good evening, doctors. I am Dr. Namra Sheikh, associated with Emcure Pharmaceuticals at Medical Advisor. I welcome you all on this digital platform for another session on or a workshop of no thrombosis series in acute ischemic stroke. It gives me immense pleasure to welcome our course director for today's session, who is Dr. Richa Poria, sir. Sir is the director at the Sayadri Hospital, and he set up the first neuro ICU and the neuro intensive care of Pune. He has been a pioneer in stroke thrombolysis and has credit of delivering more than 300 public lectures and workshops on stroke. Sir is the founder of the Pune Stroke Group and has been principal investigator for multiple national and international trials. He has been awarded as a Well by the Times of India Group. We welcome you, sir. Thank you for being on board.
Thank you. Thank you so much, Dr. Namra.
I would now like to introduce our moderator, who is none other than Dr. Manmohan Mediratta, sir. Sir is Senior Director and Senior Consultant at the Department of Neurology at BLK Hospital. Sir has been the ex-director and professor in the Department of Neurology at JIPMER. And Sir has the credit of more than 350 publications, multiple citations in highly impactful national and international journals. Sir is the editor-in-chief of International Journal of Epilepsy and has published Cochrane reviews. Sir has credit of delivering chapters in books and has the credit of providing more than 1,500 MCQs for postgraduate and postdoctoral entrance on NEET pattern. We welcome you, sir, today. Thank you for being on board.
Thank you so much. Thank you, Dr. Namra.
Our eminent speaker in today's session is Dr. R. Ramya, who is working as consultant neurologist at Tripur Medical Hospital and Aadhar Multi-Speciality Hospital. So, ma'am has the credit of being being a part of the first hospital to get the accreditation by QI all over India. Ma'am has been the author of current concepts in neurology reviews and has the credit of publications in multiple national and international journals. We welcome you, ma'am, today. Thank you so much for being on board.
Thank you, Dr. Namra.
Yeah. First of all,
so without any further ado, I now request Dr. Richa Poria, sir, to continue the session.
Yeah, it gives me great pleasure to be here today. And, we've been conducting this no thrombosis webinar for the last 1.5 years. And I must say that I've learned a lot by it. And I'm sure many people have followed it. And usually we have a following of 300 to 400 people who are taking part. And I'm very, very, very happy to welcome Dr. Manmohan Mediratta. He's been on this forum before, and his insights into cases and all you will really appreciate because he has a tremendous clinical acumen, and I'm sure you will very much benefit by his presence. We also welcome Dr. Ramya. I think, Ramya, you have presented before also, haven't you?
Yes, sir. This is the fourth time I'm presenting.
Yeah.
I would like to show the things.
Yeah. So I'm sure you'll show some wonderful cases, and we should have a very good discussion. And I'm sure Dr. Mediratta also will contribute immensely to this forum. So, Dr. Mediratta, would you like to say something?
I think that's fine. We are running behind schedule, and I have learned and heard. I have been once in this forum. That is very interesting forum. It's like a bench to bedside, practical tips, what we see in day-to-day life, in the wards, in ICU, and like Ramya is going to present like MRI negative where thrombolysis was done. So those will be of good interest, and as the case is presented, so we'll interact accordingly and useful for all the participants. Thank you.
Yes, Dr. Ramya, could you go ahead, please?
Yes, sir. Shall I start sharing my slide?
Yes.
Very good evening to everyone present here. Am I audible? I couldn't see.
Yeah, you're audible, but we can't see your screen.
Yes, that's what you're not able to see my screen, sir.
No, no, no.
1 second.
Ma'am, should I share it on your behalf? Is that fine?
Yeah, you can share, but I will tell you to change the slides then.
Yes.
Yes, ma'am, I will do.
Yeah, let Dr. Namra do it, Dr. Ramya.
Yes, sir. Yes, we can start.
Is the screen visible, ma'am?
Yes.
Yes.
Yes, yes.
Yes, visible.
Yes, ma'am.
So today I would like to present two cases whom we traumatized with a normal MRI. This is first of all, I thank you this forum and organization for giving me this opportunity again. I think I'm presenting for the fourth time. I would like to share the previous presentations, just a recall. So next slide, please. The first time I presented in October 2021, where I discussed two cases of thrombolysis in higher cortical function. The first patient had only aphasia with mild human facial palsy and no other deficit. Her NaHS score was 4. And the second patient who had a right occipital infarct had a new left occipital infarct, presented a sudden bilateral loss of vision. Presented in 1 hour. Both of them we thrombolized and they recovered completely. So I discussed like these two cases had very low NHS score at presentation, but with significant disability. So this our thrombolysis helped them, both of them. Next slide, please. Second time I presented in June 2022, I discussed two patients. The first patient was the young male with the fluctuating BP, later found to have a pheochromocytoma, whom we thrombolized, had a huge bleed post-lysis, but patient's attenders were not willing to take him to the higher center for financial reasons. So we managed only with anti-edema measures and antihypertensives. He also recovered, though he had a fixed flexion deformity on the right side and then a stroke on the left side. At the time of discharge, he has gone back to his state and started earning. The second case was a person brought for the complaints of sudden and responsiveness. No other thing, patient GCS was low. We thought could be a seizure and patient in post-ictal state. So patient was sent for an MRI. When he came back from MRI, it was actually artery of Pestron infarct with a bilateral medial thalamic infarct. We informed the attenders and we lysed him. Within 4 hours, patient got up and discharged without any deficits. Next slide, please. So the lessons were like in erratic fluctuations of BP, we should work up for the secondary hypertension in case of young patients. And in that patient, labetalol only helped us to control his BP. And it gave us confidence like we can also manage the malignant bleed with adequate BP control and anti-edema measure. And of course, stroke is a clinical diagnosis only, but at times MRI helps. So I'm going to contradict this in this presentation. Next slide, please. The third time I presented in June 2023, first case with 1.5 eye syndrome. Patient having infarct in both medial and lateral pontine syndrome, medial and pontine infarct. Patient had a delayed recovery, but after 60 days, patient recovered completely, became independent, And the second case of interest was the patient's age. She was the eldest person who was thrombolized in our hospital. Her age was 87. She also recovered completely within 5 days. So her MRS and NIHSS were 0 on day 5 at the time of discharge. Going to today's cases proper. Next slide, please. So Mrs. R, 65-year-old female, was brought to our hospital with the complaints of right-sided weakness, difficulty in swallowing, nasal regurgitation since 3 to 3.5 hours. She's diabetic and she's on diabetic and hypertensive medications with fairly good control. Next slide. Next slide. Next slide, please. Dr. Namra.
Are you facing any difficulty, Dr. Namra? So, ma'am, she might be facing some network issue. I'm just connecting with her. She will be joining in another 2 minutes, ma'am.
Manish,
My
I think
screen is
she should be allowed to change slides herself. You can just make the admin or
Ramya,
yeah.
ma'am, your slides are visible. You can please make full screen.
Yeah, thank you.
You do yourself, that will be better. Yeah.
Yes, sir. Now, I don't know what happened the previous time. So
Good.
yes. She was on diabetic and hypertensive medications with fairly good control. General on examination, her general condition was good. Hydration was good. Her BP was 164/90 in both upper limbs in supine position. Pulse was regular. Saturation was 98% in room air. Random blood sugar was 151. Her cardiovascular and respiratory systems were normal and no added sounds. Coming to central nervous system, she was drowsy but arousable, obeying few commands. She was dysarthric, right ataxic hemiparesis with the power of 3/5. Right plantar was extensor. I couldn't do the bulbar examination. She was drowsy and few commands only she obeyed. NIHSS at admission was 10. Since there was a history of nasal regurgitation, RT was inserted. These were the lab parameters which were grossly normal. Her HbA1c was 6.9. This was the MRI. It's actually a normal MRI. I would like to show that it is normal. So MRI brain with MRA was normal, which was taken at 3.5 to 4 hours of window. Patient had persisting deficits after MRI. As the stroke was a clinical diagnosis, we thrombolized her with injection tenactiflase 0.25 mg per kg at 4 hours and 15 minutes window, and she was admitted in ICU. Patient had deficits after lysis, follow-up CT brain, there was no bleed, so she was started on antiplatelets and statins. She was shifted to ward. She started improving after a day. We could remove her RT on day 2 and she was able to walk without ataxia, without support on day 3. After 3 days in the ward, again she had a similar episode of weakness, dysarthria and dysphagia. Her vitals were stable. She was planned for repeat MRI, but then she improved within 2 hours. So MRI screening was done. Again, there was no infarct or bleed. Patient was started on anticoagulants. Since the patient had an in-hospital event, the attenders wanted to shift the patient to higher center, and hence she was discharged at request. But still, we followed her. At the tertiary care level hospital, no further episodes were documented. She was continued on anticoagulants, antiplatelets, statins, and she was discharged in a stable condition without deficit. So I would like to discuss regarding the stroke warning syndromes. Shall I proceed, sir?
Yeah, Ramya, do carry on. So
Yes,
we'll
sir.
come back to the images because I observed something. But you complete the case, then we'll discuss.
Yes, sir. So stroke warning syndrome is an uncommon form of transient ischemic attack with a crescendo pattern that carries a very high risk of developing subsequent infarct. Stroke associated with this are generally localized to subcortical structures and of lacunar type. Depending on its location, either it is capsular warning syndrome if it involves anterior circulation, or pontine warning syndrome if it is posterior circulation is affected. Pontine warning syndrome, it is a recurrent stereotyped episodes of motor or sensory dysfunction, dysarthria, or ophthalmoplegia associated with a high risk of imminent basilar artery branch infarction and a permanent deficit resembling of a capsular warning syndrome. It is of diagnostic and management challenge. Because of its low incidence, it is underestimated and understudied. Pathophysiology, the probable mechanisms are hypoperfusion due to basilar branch artery disease and occlusion of the proximal portion or the ostium of the basilar branch. This is the most common mechanism. These are usually associated with a large ventral infarct, severe clinical symptoms, progressive or fluctuating course, and recurrence. Treatment, currently there's no standard treatment for this condition. However, it is important to avoid hypotension or hypoperfusion as with any stroke, with the goal being asymptomatic normotension or permissive hypertension. Dual antiplatelet therapy and statins are standard of care. So these are the articles discussing the same intravenous thrombolysis with recombinant tissue plasminogen activator in vascular warning syndromes. This was published in 2013 in New England Journal of Medicine. And the conclusion is like intravenous RTPA treatment may constitute an effective and safe therapeutic alternative for the patients with the neurovascular fluctuations. However, further studies should be designed. So another article discussing 11 stroke warning syndrome patients treated with altiplage, but they conclude the highlighted one. They conclude saying that perforating artery disease is the major pathogenesis of stroke warning syndrome. IV thrombolysis does not prevent stroke warning syndrome to ischemic stroke, but it improves the prognosis of the patients. Coming to our patient, at admission, she didn't come with any fluctuating cause of deficit, had a definite clinical deficit of with the NIHSS of 10. Her MRI was normal. As the stroke is a clinical diagnosis, or even for TAA, if at the time of examination patient is having a deficit, lysis is recommended, and hence we proceeded with the lysis. Clinical improvement was achieved after 24 hours, but patient had another episode of weakness in a similar manner, which required in 2 hours. So we consider the pontine warning syndrome. The second MRI screening was also negative. Study in the search has shown an MRI lesion only on day 6 of the established deficit. Our patient recovered completely and had no further episodes. So why should I take the benefit of doubt to the patient? 1 year ago, we had a 46-year-old male with a sudden onset of symptoms pertaining to lateral medullary syndrome. And MRI was taken at 3 hours, which was normal. So we didn't lyse the patient. Patient had a deteriorating course. We thought of demyelination infection. So we did LP, CSF was normal. And then patient went again at request to higher center. After 3 days, repeat MRI showed a medullary infarct. So this time, I don't want to repeat my mistake. So despite the MRI being normal, we lysed the patient and she recovered. Going to my second case, Mrs. B.
I think,
Ramya,
Ramya, let's
here.
discuss this case first.
Yes, sir.
Yeah. Dr. Manmohan?
Can we can we have the screen? Any question from the participants or audience? Dr. Ramya, can you just stop sharing this slide? Yeah, wonderful. So my question is that, as you said, these are like stroke warning syndromes. Since there is a definite deficit, so we need to treat that. That's very good, and it's a very interesting case. And you have given good learning points to the audience and to us as well. Now, after the second episode, patient was put on anticoagulants.
Pardon, sir?
What is the science behind? What is
Sir?
the science behind that?
So I thought
The
it is a
anticoagulants were started.
I thought it is a TAA. That's why I added anticoagulant.
No, but is there
Why?
any evidence or reference to this? That if there are two TIAs which are wide apart, not crescendo TIA, then we need to use anticoagulant with antiplatelets. Because the bleed may be
Actually,
very high until unless it is cardioembolic or something, then certainly, but otherwise, anticoagulants, to the best of my knowledge, if it is thromboembolic from a thrombotic, then anticoagulants, I think, should be avoided.
okay.
Second is when I was seeing the MRI, on the right side, the ventricle size was smaller than the left side,
Yes.
and good section of the brainstem were not visible. You said pontine warning syndrome. Why was it labeled as pontine warning syndrome? This is for the participants. Why was it labeled? What are the points in favor?
What are the points in favor of pontine warning syndrome? Patient had
Yeah.
weakness and posterior circulation symptoms like dysarthria. She had nasal regurgitations. She had ataxic hemiparesis.
No, but dysarthria, dysphagia, and ataxic hemorrhage like this can also happen near the operculum. There was one strong point which can be very helpful was altered sensorium, you said. That altered sensorium means was involving reticular activating system. If it's not large bilateral cortical infarct, then that means the reticular activating system is which resides in pons.
Okay.
So that way it becomes indicative that probably it's in the brainstem.
Okay.
And in one you said there were bithalamic. That was last time, not this case, the earlier case.
Yes, last time.
Yeah, so would have been nice to see one diffusion weighted and the other is the flare image. You
Sir?
said the MRI was diffusion weighted image, ADC, and flare image. All were normal. All were normal.
Yes, normal.
Okay. Very good. I think it's very interesting case, and if you have some data on this, you should publish this case.
Okay.
So we need to have a look on. Though we need to do the vessel wall imaging in this case, should have been done, and we should have also CT perfusion may not be helpful because we were not sure about the core and then the penumbra. So this was in view of the MRI, various stroke protocol images. You said were absolutely normal.
Yes.
Okay. Dr. Chaporia, anything?
Yeah. Sure. See, first of all, a normal scan is not a contraindication. I mean, why should you see an infarct? I mean, if the person has come with hemiplegia or with a neurodeficit and it is a stroke, it's acute onset, why do you need to see whether there is an infarct on CT scan or MRI? You don't need to see. You just need to rule out stroke mimics. You need to rule out subdural hematoma. You need to rule out subarachnoid hemorrhage. You need to rule out ICH. You don't need to see the infarct. If you do CT scans, most often the CT scan is normal. So getting a normal scan is nothing unusual, especially now with MRI, when the brainstem is involved, many times, when you do it in 3 to 4 hours, you will see a normal scan. And then you repeat the scan after 2 or 3 days, not in 6 hours or 8 hours. In 2 or 3 days, you may see the infarct. So a normal scan does not preclude you from doing stroke thrombolysis. I think this message is very, very important, because everyone wants to see an infarct and then give stroke thrombolysis. It's not at all necessary. And with brainstem lesions, when the brainstem is involved, very often, like you showed that you had that previous case of Wallenberg syndrome, the first MRI was normal.
Yes.
And then only the second or third MRI, on second or third day, it came abnormal. The infarcts are so small. Now, if this lesion was in the pons or wherever in the brainstem, it's a small penetrating vessel infarct. It is not a large vessel infarct, because the basilar artery is normal. The carotids are normal. The MCA is normal. The ACA is normal. So it's probably a small vessel infarct, a penetrating vessel in the brainstem, because there was dysarthria and swallowing difficulty. So therefore, and maybe they're drowsy. So therefore, most likely that it was a brainstem lesion. And brainstem lesions, these small penetrating vessels, the infarct is so small that you may not see it on the first MRI. And even if you don't see it, you should thrombolyze. Now, I am not convinced that this is a pontine warning syndrome, because, in pontine warning syndrome or in capsular warning syndrome, you get number of episodes of so-called TIAs and strokes. And, this could be just a recurrent stroke because of a penetrating vessel being involved. And then again, he improved. So, to call it pontine warning syndrome, I'm a little hesitant to do that. It could be, of course, it could be, because 2 episodes occurred. It could be, but I'm a little hesitant to say that, because only 2 episodes have occurred. But I would urge everyone that, normal scans are the rule. They are the rule, especially CT scan. They are the rule. And even MRI, especially if it is in the brainstem, is often the case with a brainstem infarct. So don't wait for the MRI to become abnormal and then thrombolyze, please. I think this message, Ramya, that you have given is extremely important, that even with normal scan and the deficit is there, significant deficit, NIHSS was 10, you said. So it's a significant deficit. Patient was drowsy. She was dysarthric. She had swallowing difficulty. You have to put a Ryle's tube. So she had a significant deficit, and I think you've done extremely well by thrombolizing her, and she improved and walked home. So I think what message you are giving, I think, is very, very nice. And I've always wanted to give this message to everyone, and you have brought it out beautifully. And I also agree with Dr. Mendirata that there is no need to give anticoagulant. If there is a cardioembolic source, there's AF, or there is a LV thrombus, or cardiomyopathy or heart failure, perhaps you may consider. But then you're giving dual antiplatelet plus you're giving anticoagulation. That is too high a risk to take, and there is no advantage. So I think dual antiplatelet for a few weeks to months with statin, and the stroke risk factor modification, diet, best medical treatment, what we call, would be the way to go in this particular case. And we are very happy that you took the decision to thrombolyze her early. And you did it, she came in 3.5 to 4 hours, and within 4 hours, 15 minutes, you did it. So that is also extremely creditable. That shows that your stroke pathway is well oiled and functioning beautifully. And you could do the MRI also in 10 to 15 minutes. So what do you need the MRI for? You need to rule out stroke mimics and you need to rule out hemorrhage. That's all you need. And if the patient has a deficit, the MRI is normal, thrombolize in the MRI department. No need to shift the patient here and there, because then again you're wasting 5-10 minutes. And so because you thrombolize early, she has done well. So many congratulations for having a very good and efficient stroke pathway, for taking quick decisions, and for having the guts to thrombolize with a normal MRI. So well done.
Thank you, sir. Thank you.
Professor?
Yeah, I agree. You said they did thrombolize in time.
Yeah.
Not that she took the decision, but she took the right decision.
Yes.
That's very important.
Yeah,
Thank you.
she's had, I think she's burnt her fingers before, like all of us. All of us have burnt our fingers many, many times. But the important thing is, after burning fingers, she's improved and gone one step ahead. So all of us, Ramya, we have burnt our fingers. I've burnt fingers, toes, face, mouth, tongue, everything. But at the end of the day, we have to improve ourselves and learn from every so-called error that we have made. I mean, it's not an
Yes.
error. It's a matter of judgment. It's a matter of training. It's a matter of conviction. There are so many factors which come in. So
Yeah.
I'm very happy that you have improved on your previous experience and come up trumps in this experience.
Honestly, I think we are running late.
Yeah.
You can go to second
Yeah.
case.
Yeah,
Yes, sir.
And
Dr.
all the
Ramya,
best to you.
any
All the best.
other point you want to make? Anyone, with the professor? Any other point?
No. All the best. You have burnt your
Yeah.
fingers, feet, and so many
Yeah.
things. So all the best to you, Nasli,
Yeah. Yeah.
for future.
Thanks.
Yeah.
Yeah, Dr. Ramya.
Yeah, Ramya.
Next case.
Go to
Yes,
next case.
You have the next case, no, Ramya?
yes, sir. Yes, sir. I'm proceeding.
Yeah.
So, my second case is Mrs. V. She's 49 years old. She's also on treatment for diabetes and hypertension. She was referred from ophthalmologist for the complaints of dimness of vision in the right eye for past 1 hour. This patient on April 9th of this year consulted the ophthalmologist for the pain in the right eye for 3 days. At 11:45 a.m., she was examined in the hospital. Her visual acuity in the right eye was 6/6 with spectacles and near vision was 6, and left eye also 6/6 with spectacles and near vision was 6. So she finished her ophthalmic evaluation and went out for lunch. Had a sudden deterioration in her right eye vision around 3:30 p.m. and she has gone back to the same consultant. After 3:30, her visual acuity was in the right eye was only hand movement perceptions. Left eye was as before. The fundus examination showed mild non-proliferative diabetic retinopathy with right eye query early CRAO. She was referred to us as a case of acute retinal ischemia within the window period. The ophthalmologist has sent the patient to MRI from, it is a different hospital, it is not our hospital. The hospital is like 10 minutes away from our hospital. So, and the scan was on the same direction, another 10 to 15 minutes. The ophthalmologist has sent the patient to MRI with MRA and then referred to me. So patient came to me with the MRI brain with MRA of cerebral and neck vessels. Brain was normal, cerebral vessels were normal, neck vessels showed a moderate to diffuse luminal narrowing of 50 to 70% of right ICA from its origin. Patient clinically had no deficit and her vitals were all stable. Her random blood sugar was 128. Blood parameters were normal except for the uncontrolled sugar with the HbA1c of 10.1. So patient and attenders were explained about the pros and cons of IV thrombolysis. They gave consent. So we lysed her with injection tenecteplase 0.25 mg per kg at 2 hours and 50 minutes window. And she was admitted in ICU. She was closely monitored for any bleeding complications, oral GI. Follow-up CT brain was done. There was no bleed. She was shifted to ward, started on antiplatelets and statins. Um, uh, and she gradually improved. Ophthalmologist reviews obtained. After stabilization, she was referred to tertiary care hospital for the carotid artery disease. She was also started on low molecular weight heparin because of the carotid disease. These were her follow-up visual acuity. At admission, her visual acuity in the right eye was perception of hand movements. By next day, it became finger count at 1 meter. By 2 days later, it was 6 by 36 and N18. And on day 6, it was 6 by 18 and N12. Few articles regarding the same thing. This was published in 2019 Stroke Journal, Thrombolytic Therapy for Acute Central Retinal Artery Occlusion. I'm just taking a few important points from this article. It causes the interruption of blood flow to the retina, resulting in acute onset of retinal tissue dysfunction. It is a form of ischemic stroke, like cerebral stroke. It can occur because of large artery atherosclerosis or embolism, inflammatory vascular disease, or hypercoagulability. Only 17% they regain a functional visual acuity in untreated patients. And in 50% of the affected patients, only the remaining visual field is a small peripheral island. It affects both men and women equally, and the incidence increases with age. It has both arteritic and non-arteritic forms. The thrombolytic therapy is recommended for the non-arteritic form of CRAO, which accounts for 95% of the cases. Blood supply of retina. Central retinal artery is a branch of ophthalmic artery, which is the first branch of internal carotid artery. Retina has two vascular networks, both arising from ophthalmic artery. The retinal artery circulation supplies the inner retina, while the choroidal network supplies the outer retina and the choroid. The retina is extremely metabolically active, and it is totally dependent on the constant availability of substrate for the anaerobic glycolysis. The degree of cell death in the retina is correlated with the duration of occlusion of CRAO. In the older animals with experimentally induced chronic hypertension and an atherogenic diet, irreversible tissue loss did not occur until 240 minutes after the occlusion. So they conclude that central retinal artery occlusion should be treated in an emergent fashion in the same manner as the acute cerebral ischemic stroke. It is not only an ophthalmological problem, it is a disorder of cerebral arterial tree that affects the retina. There is a need for further randomized control trials with different agents within the window period of 4.5 hours for this devastating condition. So this is another article published in 2020 in the Journal of Neuro-Ophthalmology. They also say like non-arteritic CRAO should theoretically receive the same thrombolytic therapies in the same window as with the acute cerebral ischemia. It should include an expert ophthalmologist to confirm the correct diagnosis and to evaluate the ocular signs that may help guide IVTPA administration or IA management. This is another article from Journal of Neurology. This is a retrospective observational study. And they also say like early intravenous therapy according to the current stroke protocol in the time window of 4.5 hours after the onset of symptoms was feasible and might be a potential treatment option for non-arteritic CRAO. And the patients are at very high risk of ischemic stroke, and hence MRI should be done in all patients for the optimized treatment and secondary stroke prevention. Coming to our patient, this is what we did for our patient. Ophthalmologist only diagnosed and this condition, and follow-ups were also done with him. She was lysed within the window period after an MRI. Vision improved to near normal. To avoid further retinal and brain ischemia, she was referred to a tertiary care center for the carotid artery disease. Thank you.
Fantastic.
Sir.
Can you
Fantastic.
stop sharing? Can you stop sharing?
Yes, sir.
Yeah, Ramya, another wonderful case, and we also encountered similar case recently. but patient was already thrombolized. Then patient had later amaurosis fugax, monoocular amblyopia. So, but we could not do. Then the ophthalmologist did fenestration, and that was helpful, and patient is slowly improving. But can I ask you, Ramya, what was the fundus like?
Sir,
Fundoscopy.
fundoscopy,
Fundoscopy.
mild non-proliferative diabetic retinopathy.
No, no. In addition, CRA or any signs which you could get like cherry red spots or pale optic disc.
No, sir didn't mention anything like that, but he wrote early CRAO picture, but also said like new vascularization of iris was noted, which is an indirect evidence of carotid artery disease and chronic small ischemia
No,
causing
no. See,
this.
patient has got suppose amblyopia. Now, this patient is classical. There are risk factor, everything. How do you know it is psychogenic or genuine? What was pupil like? What was fundus like? What was it like? Was there any cherry red spot? So those are very important points
Okay, sir.
which need to be seen. Yeah, but very nice case and very interesting case. Thank you.
What was the
Yeah,
pupil?
Dr. Ichapuri.
Yeah, Ramya, what was the pupil and was there an RAPD?
No, that's what not mentioned.
Yeah, exactly what you asked.
Yeah.
Sir, I don't remember.
Okay,
I
Okay.
no
didn't
problem.
pay attention to that because
Yeah,
with the
no, because you know
diagnosis.
what professor is saying,
Yes,
that
sir.
how can you be certain that it is not functional? So, you know, the pupil, see, the cherry red spot will take time to come.
Yes.
You know, when it's done so acutely, we don't have time for, you know, the retina to get infarcted. Probably the retina is just ischemic. So only when the retina gets infarcted and the retina becomes pale, only then later on you see cherry red spot. So acutely you will not see cherry red spot. So you have to go by clinical judgment that really there is optic nerve involvement or retinal involvement, and therefore you should see the pupil and look for RAPD, because that will rule out functional cause, and it is really organic. But besides that, I must congratulate you, because it is very rare for anyone
Yeah.
to diagnose central retinal occlusion and act so quickly. And you know, the patient was in another hospital, had to be transported to your place within 10 minutes, and you thrombolize the patient. And you must be a handful of people in the world who have done this. Handful. And I've done about one or two only in my career, but I must say that, you know, because you acted so quickly, though there is no randomized control trial for TPA in acute retinal this thing, there is no, but it stands to reason, you know. I mean, if it's part of the brain, and the rest of the brain, we have found that it works so well. So why should it not work in the retina? But there is no focused RCT on central retinal occlusion. But certainly within 4.5 hours, you should give it. Now, another point is next.
Chaporia, Nasli,
Yes,
there
sir.
will be very few cases of such
Exactly,
type.
very few.
So maybe difficult to have
Very
randomized
difficult.
control trial.
That's what I'm saying. Very difficult. Very difficult to do an RCT on this, you know, because how many cases will you get? And then you'll have to randomize giving placebo and giving TPA. So, you know, it'll be almost impossible to do this trial. So, but still we have to extrapolate and do good for our patients. Everything, there is no trial, and there cannot be a trial for everything. So you have to use your little judgment and common sense, which you have done and demonstrated it most beautifully.
Nice.
And now, you know, you should look at the carotid and maybe do revascularization. If it is, you said it was 70%, 50 to 70, you said.
50 to
So
70%.
maybe, you know, to prevent stroke recurrence, because this is like a TIA, or in fact has been converted to TIA by your action. And therefore, to prevent further strokes, you will need to give best medical treatment with DAPT and statin, and perhaps you may, if the stenosis is significant or there's an ulcerative plaque, you may have to revascularize this patient by endarterectomy or stent. So you should take it to the next level and don't let the patient go, because a recurrence can occur, and a stroke can happen, a brain stroke can happen, not a retinal stroke, only a brain stroke can happen. So you should take it to the next level. But because of your quick action and this, you need to be heartily congratulated for saving this person's vision. And don't think that, only losing one eye, okay, the other eye is there, but, it decreases the enjoyment and quality of life.
No,
The
no, never,
person has
Nasli.
difficulty in driving.
Nasli,
Yeah.
never like that. Yeah, we should never. Yeah,
Yeah.
every body part is
Yes,
vital,
absolutely.
vital role.
No,
Yeah.
no, people argue ki kya hua? One eye is gone, other eye is there. No. This is all bunk. Because quality of
Yeah.
life goes down. He can't drive. He can't, this enjoyment of life goes down. He's anxious. Family's anxious. So certainly it has to be treated. Don't take it lightly. Don't take it
Congratulations,
lightly. And
big, yeah,
wonderful, wonderful.
big, big congratulations, Ramya,
Yes,
sitting in smaller place
absolutely,
also.
absolutely.
You have done a wonderful job, and we all need also to, you are encouraging us also to do the same
Yeah, of
in bigger
course.
centers. Yeah,
Thank you, sir. Thank you for your
yeah,
kind words and
yeah,
encouragement.
yeah,
I'll keep
yeah.
going.
Yeah,
Wonderful,
yeah.
wonderful.
Thank you.
Okay.
Okay, then if I don't
Any
think there are any
questions from the
questions.
audience?
Doesn't look like.
No,
Arey,
sir, not yet.
what? Everyone's sleeping or what? Such good
So
cases
nothing
were
like
there.
that. Such interesting cases. Such interesting cases.
Yeah,
Even
Yeah,
I'm
yeah,
sleeping on
very
very,
it.
interesting. And
very interesting,
with this
Namra,
case,
and
Ramya, many people should do CRAO thrombolysis. Many people should
Yes.
do. People
So
get
this
scared.
was the
And,
first
and
case.
ophthalmologist doesn't send in time. That is the big problem.
So this
Then
was
they
the
will do
first.
some OCT and this and that and check the pressure and waste time. Here, though, if you see acute blindness, you must immediately send to the stroke department and do the scan and this thing. So also we must congratulate the ophthalmologist for picking it up very quickly and sending it and not wasting time doing all those useless investigations. CRAO is a medical emergency, and it has to be treated by the stroke team. It cannot be treated by the ophthalmologist. The ophthalmologist, then they do some vitreous, what do they do? Some aqueous
decompression,
drainage
decompression.
and
Yeah,
some vitreotomy, all useless.
anterior chamber. Yeah, they do it.
Anterior
Yeah,
chamber to reduce
in
intraocular
our
pressure,
patient,
or they rub the
that
eye.
was done.
All
Yeah.
bakwas. It
Okay,
doesn't work.
but
It, it
yeah,
doesn't
I
work. The
think
treatment is stroke thrombolysis.
yeah,
So,
we
I
got a
often have these
message.
fights with ophthalmologists because they want to do anterior decompression, and they want to drain the aqueous, and they want to do something with the vitreous, and they want to massage the eye, and they want to give some hyperbaric oxygen and or carbon dioxide or something like that. Nothing of that has been proven to be useful. Though it's not proven because an RCT is not there, but it stands to reason that it will work. So I think you have encouraged many people, and including both of us, I'm sure, to do this and to train our ophthalmologists. Kyare Baba, such a case comes, please send quickly. Don't waste time for 6 hours, then we can't do anything. And as you said, 240 minutes only it is viable, no? What did you say, 240?
40 minutes.
Yeah, exactly. So
4 hours.
240 minutes is what? 4 hours, no?
4 hours.
Yeah, 4 hours. So, if you waste time here and there by doing unnecessary tests, you miss the window. And the ophthalmic artery is so small, you cannot do mechanical thrombectomy. So you have to rely on IVT. Because the mechanical, the catheter is the artery is too small for any catheter to go in at present. Unless there's some large occlusion of the ICA at the siphon or something, which is very uncommon to produce this type of syndrome. So the treatment really is IVT. but early identity. So also, Ramya, please congratulate from all of us, your ophthalmologist.
Sir, I would like to share the previous presentation, acute visual, bilateral visual loss. That patient was also sent from Dr. Gautam Kukadia. She diagnosed, he
So
did a
on our
MRI and
behalf,
then came to me.
please congratulate him and
Sure,
thank
sir.
him.
I'll tell him, sir.
Yeah, please tell him that all of us have thanked him.
Yes.
Yeah, because, not many people do it. Not many people do it. I've had problems with them. I've had fights with them, and I'm the bad boy, but this is how it's to be done. Professor, any comments?
Yeah, excellent case, good learning points. And in the chat box was 421 HCP. If that is so, if we can benefit 4 to 5 patients in this remaining 5 months of this case will be worth it. This presentation will be worth it. And let people benefit the public at large by recognizing early, identifying early, high index of suspicion, proper diagnosis, and as Nasli said, the proper line of action and quick action. Thank you so much. I think we can close now if there are not other questions. Yeah.
Sir, I would like to share our hospital has got the accreditation for primary stroke care center, first time in India, first hospital in India.
Yeah, we read. I went to Calcutta for CMRI. That was comprehensive stroke care. But congratulations for that also, primary care. And soon you should have comprehensive care.
Yeah.
Stroke center. Yeah.
Okay.
Excellent.
Thank
Excellent.
Okay.
Thank you. Thank you so
Very
much.
nice.
Thank you, sir. Thank you very much.
Yeah.
Over
Thank
to
you
the
so
host.
much, sir, for
Over to Dr.
providing time.
Namra. Over to Dr. Namra. Yeah.
Thank you, sir. Thank you so much, sir, for providing time for this meeting. We are extremely grateful and thankful to you for the same. Thank you, Dr. Ramya, madam. Thank you for giving time for this meeting. And the cases which you discussed were really insightful, and I'm sure the audience might have benefited with the same. So today we had 421 logins. And
that's pretty good, huh? That's a pretty
so
good
soon
number.
we will.
So 421 people
Absolutely.
know you, Dr. Ramya.
Thank you for the opportunity, sir.
Okay.
Okay,
Great.
so soon we will be meeting for another exciting session of No Thrombosis workshop series and stroke. Till then, good night.
Good night. Good night. Thank you, everyone.
Thank you, sir.
Good
Thank you,
night.
Manmohan sir. Thank you.
Good night.
Good night.
Nasli sir. Good night. Thank you.
Good night.
Thank you, Ramya. Thank you,
sir.
Namra.
Thank you, sir.
Thank you, Ramya.
Thank you. Thank you, Namra.